Namaste to all the great doctors of this country. A warm welcome, lovely good afternoon to everyone. My dear friends, I hope you appeared for the test and I hope you would have done great. Namaste, everyone. And right. So, I hope you would have performed nicely in the test. Few questions which I received from some of the students. One question was related to at 1 year of age, what will be more important, whether it was velopharyngeal story or not. So after 1 year, we know that speech would be taking the most important priority. That is why velopharyngeal competence is important. So that is why it was preferred over feeding. Right. Apart from this, there was a question which I received from some of you that there is a cleft of the lip in the nose. So what will be the timing of repair for that? The answer there was 3 months in that particular question. So I hope you would have really done great. If you have got any doubts, please do write in the class. And majority of the doubts, one more thing which I would like to share, that some of the students have shared on a DM to me that it's better that we take all the doubts after the class is done, because many students do suffer from those doubts. So we'll try to figure out that what are those doubts which are important to clear while the class is going on, and what are those doubts which we can answer later on. So we'll take the things accordingly. Right. Like just now you have written that which is the most important modality to see the extent of cystic hygroma in the neck. Now they are asking most appropriate. In most appropriate, the first investigation what we do in cystic hygroma would be ultrasound of the neck for sure. But when we have to see the extent, then when our classes will go on, we'll realize that wherever there are nerves, vessels or muscles, then MRI is preferred, like head and neck area and the pelvic area where there are a lot of muscles, we prefer doing MRI. Right. Okay, great. So the first thing which we want to do today is we just want to revise the pediatric surgery. हाँ, तो इसीलिए बेटा रवि मोस्ट अप्रोप्रिएट अगर वो पूछ रहा है तो मोस्ट अप्रोप्रिएट विल बी एमआरआई, बट इट विल बी डिफिकल्ट टू गेट दैट एमआरआई डन इन स्मॉल बेबीज. दैट इज व्हाई वी प्रेफर डूइंग अल्ट्रासाउंड. ओके, चलिए तो लेट अस फर्स्ट वील रिवाइज दिस with the workbook, and I would request the admin team also to take care that we'll be putting this in the revision part. Right, so first we'll revise with the workbook and then without the workbook as well. Okay, beta. So in pediatric surgery, we'll focus in a sequence from top to bottom, like in the face, cleft lip and palate, neck, thyroglossal cyst, branchial cyst, branchial fistula, cystic hygroma, thorax, esophageal atresia, dysphagia, leusuria, in the abdomen, in the epigastrium, duodenal atresia, annular pancreas, hypertrophic pyloric stenosis, right hypochondrium, biliary atresia, choledochal cyst into susception, lumbar region, ectopic kidney, polycystic kidney, horseshoe kidney, right iliac, Meckel's diverticulum, left iliac, Hirschsprung disease. And then in the hypogastrium, duplication of renal pelvis ureter, retrocaval ureter, uretrocele. In the urethra, boys, posterior urethral valves, hypospadias, scrotum, undescended testis, and at the back, imperforate anus. Now, if we look at this cleft lip and palate, then cleft lip and palate combined, they account for 45%. Cleft palate alone 40%, cleft lip alone 15%, where left-sided cleft lips are more common. Why these cleft lip palates occur? Maybe genetic story, family history, maybe environmental factors like maternal epilepsy or drugs taken by the mother during pregnancy like phenytoin, diazepam, steroids. This can be associated with various congenital heart diseases as well. It can be associated with various syndromes like Van der Wood, Stickler, DiGeorge, Down, Shepard, Streecher, Collin, Pierre-Robin and Patau syndrome. Role of folic acid supplementation during pregnancy is equivocal. If we have to decide what is complete cleft palate or incomplete cleft palate, if the cleft in the palate and the palate is attached with the vomer and the nasal septum, it is incomplete. But if there is cleft in the palate and the palate is separated from the vomer nasal septum, it is complete cleft palate. The reason for development of this cleft lip and palate is if there is failure of fusion of the median nasal process, then it results in cleft of the philtrum and the alveolus. If there is failure of fusion of the median nasal process with the maxillary process, then there is cleft in the nose and the lip. And if there is failure of fusion of the two maxillary process, there will be cleft in the palate. However, the most often asked MCQ in this is if the median nasal process fails to unite with the maxillary process, it results in cleft of the nose or the lip. The problems which the baby can face with this cleft lip palate would be related to airway, breathing, swallowing, dentition and speech. Cleft lip can be diagnosed on antenatal ultrasound after 18 weeks of pregnancy. And the treatment for these cleft lip and palate would be definitive surgery, that is plastic surgery, plastic reconstruction. Now, what is the ideal time or what should be the approach in these cleft lip palate babies? The algorithm says first 2 months we don't do any surgery, we just focus on building up the baby, focusing on his nutrition, feeding part, wherein there are modified feeding bottle teats and parents are trained for that squeeze and suck technique. 3 to 6 months is the time to repair the nose, lip and the hard palate or the anterior palate, especially the bony part of the hard palate. 6 to 12 months is the time to repair the soft palate, that is veloplasty, intravelar veloplasty. In cleft lip repairs, we mainly focus on muscle reconstructions, and in soft palate repairs, we focus on the levator sling reconstruction. 1 to 7 years of age, we focus on the feeding part, dentition, speech and the aesthetic part, where speech becomes the most important, especially at 1 or after 1 year of age. Then 7 to 12 years of age, we have to do any alveolar bone grafting if there is any cosmetic disfigurement. Millard's operation is done mainly for the lip and Wardell's is done mainly for the palate. Right. Now, if we look at the neck swellings, midline neck swelling is a thyroglossal cyst, lateral swelling is a branchial cyst, and posterior triangle of the neck is cystic hygroma. Thyroglossal cyst, this is because of accumulation of secretions in a persistent thyroglossal tract. A thyroglossal bud grows from the foramen cecum on the tongue and it goes down exactly in the middle of the neck, and in the lower part of the neck it forms the thyroid gland. And after development of thyroid gland, this thyroglossal tract completely obliterates. But if this thyroglossal tract remains patent even after birth, there may be accumulation of secretions anywhere in this patent thyroglossal tract, which will lead to a thyroglossal cyst, most commonly seen in children located below the hyoid bone in the midline. However, if it is located near the Adam's apple or thyroid cartilage, it may be found on one side of the midline. The characteristic features of thyroglossal cyst would be it will move not only with deglutition, but it also moves with protrusion of tongue. As the tongue is coming out, the cyst is also moving. This cyst can complicate into thyroglossal abscesses, which can rupture, leading to thyroglossal sinus and thyroglossal fistulas. Remember, thyroglossal cyst is congenital, but sinus fistula is never congenital. Thyroglossal sinus fistulas, they are always acquired. Long-standing thyroglossal cyst can lead to papillary thyroid cancer also. And sometimes this can be confused with ectopic thyroid tissue. Whenever we talk about any fistula, it would be having an external opening, and we try to put a wire type of instrument, that is probing, to see for how much length the tract is going inside. Whether it is just ending blindly, it would be sinus, but it is going opening somewhere, it would be fistula. Because thyroglossal cyst can lead to the complications like papillary thyroid cancer, so we have to excise this thyroglossal cyst. Not only cyst, but we also have to excise the entire thyroglossal tract right up to foramen and cecum on that tongue. That is cyst trunks operation. Excision not only of the cyst, but also of the entire thyroglossal tract, including the central portion of hyoid bone up to the foramen and cecum on the tongue. The lateral neck swelling in children or maybe middle to late adulthood is a branchial cyst, which may be a remnant of second branchial cleft, and sometimes we can find a branchial fistula, which is due to persistence of the second branchial cleft. Now, this branchial cyst and branchial fistula both are located on the anterior border of sternomastoid muscle. However, cyst is located slightly higher up, that is at the junction of upper 1/3 and middle 1/3 of the neck, while the external opening of the branchial fistula, that is in the lower part of the neck. The branchial cyst is lined by squamous epithelium, while branchial fistula is lined by ciliated columnar epithelium. Internal opening of branchial fistula is located anywhere in the pharynx area, Most often it is located behind the tonsil on the anterior aspect of posterior fascial pillar. However, it can open in the pyriform sinus area in type 3 and type 4 type of branchial fistulas. The treatment, whether it is branchial cyst or branchial fistula, would be excision. Like in fistula, we have to excise the complete tract, complete excision. Cystic hygroma, which is seen in the posterior triangle of neck, this is actually a lymphatic swelling due to sequestration of various jugular lymphatic sac. And this sequestration causes those lymphatic sacs to join with each other and the lymph starts getting collected there. And this leads to a swelling in the posterior triangle of the neck. During intrauterine life only, this swelling may start, and sometimes this swelling can become so big that it can even obstruct labor. 50% of cystic hygromas, they do present to us in the neonatal period very early in life. This cystic hygroma will be lined by endothelium, and because it will be having a clear fluid inside, so it will show positive transillumination. Any swelling in the body which has got clear liquid inside will show positive transillumination. The most brilliantly transilluminated swelling in the body is cystic hygroma. However, other swellings which show positive transillumination include ranula, hydrocele, meningocele, and rarely branchial cyst. The treatment for these cystic hygromas would be complete excision, or we can even do sclerotherapy injection. If you have to choose what is the most appropriate, go for surgical excision. If we have to put the injection and destroy the swelling, we prefer a medicine picibanil, which is marketed by the trade name OK432. Now we move in the neck, from the neck we move into the thorax area where we talk about esophageal atresia. This is absence of some portion of the esophagus, and it is because of the posterior deviation of the tracheoesophageal septum. That is why the two ends of esophagus are not able to meet with each other. And most oftenly we find that the upper esophagus is blind while the lower esophagus is connected to the trachea. So any abnormal relationship between two people is a fistula. So this is a tracheoesophageal fistula for the lower esophagus. However, there can be various different types. For example, if this is the trachea, this is the esophagus, then type 1 will be when upper and lower esophagus both are blind, nobody is connected to trachea. Type 2 when the upper esophagus is connected to trachea. Type 3 when the lower esophagus is connected to trachea. Type 4 when both upper and lower esophagus are connected to trachea. And type 5, there is no atresia of the esophagus. There is just a abnormal connection between the trachea and the esophagus. This is isolated tracheoesophageal fistula or a H type of fistula. However, most common is type 3 or type C. This can be associated with various other congenital anomalies which are remembered by the mnemonic VACTERL. Remembered by the mnemonic VACTERL, wherein V stands for vertebral, A for anorectal, C for cardiac, T for tracheoesophageal fistula, R for renal, and L for limb defects. Out of these, most common are the cardiac anomalies. This can be either ventricular septal defect or maybe patent ductus arteriosus or maybe tetralogy of Fallot. These are the commonest congenital anomalies associated with esophageal atresia. Now, during pregnancy, what can happen? Whatever saliva is there in the baby's mouth, that saliva may not be going in the stomach, so it will be coming back and it will be increasing the volume of amniotic fluid. That is polyhydramnios. However, after delivery of this baby, immediately after birth, whatever saliva will be there, that is also not going down. So all this story is coming back. So there will be continuous frothing or continuous pouring of saliva from the baby's mouth within 20-30 minutes after birth. And this will carry a high risk of regurgitation, aspiration, and pulmonary complications. Remember all the great doctors, whenever there will be any traffic jam in the esophagus, whether it is esophageal atresia, dysphageal ursuria, eclasia cardia, nutcracker esophagus, diffuse esophageal spasm, Schatzki's ring, Zenker's diverticulum, carcinoma of the esophagus, all this story, whenever there is a traffic jam, the commonest complication we see will be the pulmonary complications. Right. Now, if the baby is continuously pouring saliva from the mouth, then we suspect there can be esophageal atresia. So, initial bedside test in the labor room would be nasogastric tube, and failure to pass the nasogastric tube beyond 10 centimeters will give you the idea about esophageal atresia. To see this, you can take the chest x-ray, and in chest x-ray, you can nicely see there is coiling of the nasogastric tube in the upper esophagus, or you are not able to pass the nasogastric tube down. If in this x-ray you are able to see gas in the abdomen, that means there is connection of the trachea with the lower esophagus, because of which whatever gas is coming in the trachea, that is going in the lower esophagus and then into the stomach, duodenum, intestines. So gas in the abdomen suggests connection of the lower esophagus with the trachea, that is seen in type 3 and type 4, or it can be a type 5 where trachea is separate, esophagus is separate, and there is no atresia, just a fistula. So there also you will see gas in the abdomen, that is type 5. If you don't see gas in the abdomen, that means there is a possibility that either it is type 1 where there is no connection of the esophagus with the trachea, so no gas is going into the abdomen, or there is a type 2 where there is connection of the upper esophagus with the trachea. So again, no gas is going in the abdomen. So type 1, type 2, no gas in the abdomen. Type 3, type 4, type 5, there will be gas in the abdomen. In the treatment for esophageal atresia, you have to divide the fistula and you have to do esophagostomy. To know where is the lower esophagus, you do a CT scan where you can even use a contrast. Now, CT scan can be done maybe on day 1, day 2 of life, and if that says that the two ends of esophagus are close to each other, then you do a thoracotomy, divide the fistula, and do a esophagostomy and restore the GI continuity. This is done maybe on first day of life or second day of life. However, if the CT says that upper and lower esophagus are far from each other, then if you try to join these far ends, there would be tension in the anastomosis and the sutures can break. So it is better you wait for 4 to 6 weeks, let the two ends of esophagus grow, reassess after 4 to 6 weeks. If you find that the two ends have come close, you do the anastomosis. But if you find that even after waiting for 4 to 6 weeks, the two ends have not come close, then you have to do esophageal reconstruction using colon, jejunum, or the stomach. In the waiting period, we prefer doing a feeding gastrostomy for giving nutrition to this baby. We can also do a feeding jejunostomy. Right. So that is how we have to play this game. Now there is dysphagia lusoria. Dysphagia lusoria is when there is compression of the esophagus by aberrant right subclavian artery. Like there can be aberrant right subclavian artery which can compress the esophagus from outside and cause dysphagia. However, dysphagia can also be caused by double aortic arch or right aortic arch. If we look into the abdomen in the epigastric area, duodenal atresia, annular pancreas, and hypertrophic pyloric stenosis, duodenal atresia is absence of some part of the duodenum because of failure of fusion of foregut with the midgut. Now, if there is duodenal atresia, say this part of the duodenum is missing. Generally, this atresia is seen below the opening of bile duct. So what will happen? The proximal people are going to get dilated. The pyloric area will not dilate because this is sphincter. And because of proximal dilatation, the pressure in the proximal part will increase and there will be forceful vomiting. This is bilious vomiting. Within few hours after birth, maybe within 4 to 6 hours after birth, or sometimes maybe within 1 or 2 days after birth, the baby presents with bilious vomiting. If you take a X-ray in this baby, because duodenum was dilating separately, stomach was dilating separately, so you see double bubble sign. Double bubble sign is suggestive of duodenal obstructions. However, only single bubble sign would suggest pyloric obstruction. If there are triple bubbles, like here, this is stomach, this is duodenum, and this is jejunum. So this is seen in jejunal obstructions where jejunum dilates separately, duodenum dilates separately, and stomach dilates separately. Why stomach and duodenum are separate? Because of pyloric sphincter in between which cannot dilate. Why duodenum and jejunum dilate separately? Because there is ligament of Treitz at the junction of duodenum and jejunum. So that does not allow the duodeno-jejunal junction to dilate. That is why duodenum dilatation is separate, jejunal dilatation is separate. If you see multiple air bubbles or multiple air fluid levels in the central part of abdomen, this is small intestinal obstruction. If you see multiple air fluid levels in the peripheral part of abdomen, this is large intestinal obstruction. Duodenal atresia is the most common cause of intestinal obstruction in a newborn baby. However, overall the commonest cause of intestinal obstruction are the post-operative adhesions. Also, most common GI anomaly associated with Down syndrome is duodenal atresia. And the treatment for duodenal atresia would be, ideally we connect this duodenum with this duodenum, that is duodenostomy. But if by chance the two ends of duodenum are far from each other, and because duodenum is fused with the pancreas, so we are not able to mobilize the two ends of duodenum, in such cases we have to request the innocent guy, Sharif Admi, and we connect the duodenum with the jejunum. That is duodeno-jejunostomy. This is the alternative treatment. Treatment of choice will be duodenostomy. Annular pancreas, this is a ring of pancreatic tissue which surrounds the duodenum. This can also create duodenal obstruction, present with double bubble sign, and the treatment will be chopping the duodenum above and below and joining this duodenum with this duodenum, that is duodenostomy. If this ring is wide and there is a big gap between the two duodenum, then we prefer doing a duodeno-jejunostomy. Hypertrophic pyloric stenosis, that is infantile, it is idiopathic, nobody knows what happens, but there is hypertrophy of circular muscle fibers of the pyloric musculature. And usually this is seen in the first-born male child in the family. And the incidence is 2 to 3 per thousand live births. Because it takes some time for the pyloric muscle to hypertrophy, so it does not present immediately after birth. It generally presents between 2 to 6 weeks of life. Most often, third week of life. How this baby will present? There will be olive lump in the right hypochondrium or epigastrium. And this lump is not the distended stomach, it is actually the thick pyloric muscle fiber. When we give a test meal, say milk, to this baby, we can find vigorous peristaltic movements from left to right side. Because there is traffic jam at the pylorus, so the stomach is going to get dilated, pressure in the stomach will increase, and the stomach muscles will contract forcefully, and there will be projectile non-bilious vomiting. Obviously, this content is going to come out and there is no bile in the stomach. Bile will be coming in the duodenum second part. So there will be projectile non-bilious. Why projectile? Because of the force of gastric muscles. Because gastric contents will be getting lost, acid is getting lost, so there will be metabolic alkalosis inside the baby. And in vomiting, chloride is getting lost, HCl, so there will be hypochloremia. In this baby, initially, because of metabolic alkalosis, the baby's kidney will try to maintain a homeostasis. And for that, the kidneys will be throwing alkali in urine. That means initially urine of the baby will be alkaline. But if the baby is continuously vomiting, maybe 2 days, 3 days, 4 days, then baby is getting dehydrated. And if baby is getting dehydrated, that means volume in the pipeline is going down. Pressure in the pipeline is going down. Oxygen supply to the vital organs is going down. That means this baby can die. You are the second God. You cannot allow this baby to die. So you will have to pump in IV fluids to generate sufficient pressure in the pipeline so that oxygen can reach to the vital organs. Before this baby presents to you, God will try to do some compensation in this baby. If the volume in the pipeline is going down, pressure in the pipeline is going down, then God tells the kidney, you will have to conserve water. So there is stimulation of that ADH, and that causes reabsorption of sodium and water from the kidney. When sodium is getting reabsorbed, then potassium and H ions will be excreted in urine. If potassium is going out in urine, that is kaliuresis, and that causes hypokalemia. Hypokalemia. If H ions are getting lost in urine, urine is becoming acidic. Ideally, because the baby was having metabolic alkalosis, the urine should have been alkaline. But to save water, sodium is getting reabsorbed. That is why potassium H ions are getting excreted in urine. If H ions are getting excreted in urine, urine has become acidic. So ideally it should have been alkaline, but it is becoming acidic. Opposite is happening, ulta ho raha hai. So we call it as paradoxical aciduria. Now, first and foremost thing for the great doctors in June 2026, they have to save the life of this baby first. They have to generate pressure in the baby's pipeline. So you will have to pump in IV fluids, do the electrolyte correction, make the baby stable. Then you do the clinical examination, and if you are feeling a lump in the abdomen, then the first investigation for any abdominal mass or lump will be ultrasound. And ultrasound is the investigation of choice for hypertrophic pyloric stenosis, because this can show the thickening of the pyloric muscle more than 3 to 4 millimeter, or lengthening of the pyloric canal more than 16 to 17 millimeter. That favors the diagnosis of infantile hypertrophic pyloric stenosis. In the treatment, we want to release the traffic jam. So initially, we can try doing a pneumatic balloon dilatation. But this may be just temporary. Again, the pylorus may stenose. So a permanent solution or the most appropriate treatment would be surgery, where you have to cut the serosa, then cut the muscle fibers. So this is seromyotomy. This is Ramstead seromyotomy. Right. In the right hypochondrium for biliary atrasias. Biliary atresia is absence of biliary channels. The exact cause is not known, but it is believed that probably in the first week of life, there is inflammatory fibrosis of the biliary channels, and because of which these biliary channels may become absent. Depending on which channel is absent, we can classify biliary atresia into 3 types. If only CBD is gone, it is type 1. If CBD and CHD both are gone, type 2. If CBD, CHD and right-left hepatic ducts all are gone, this is type 3. Most common is type 3. Whether it is type 1, type 2, type 3, problem is the bile which is forming in the liver is not going into the intestine. So, whatever fat is going into the duodenum, that will not be digested. There will be steatorrhea. Plus, because bile is not going down, bile is going up, so this will cause congestion inside the liver, hepatomegaly. Plus, this bile will be going back into the sinusoids, into the blood, that is jaundice. Jaundice, hepatomegaly and steatorrhea starting in the later part of first week or second week of life. How to approach this baby? If there is jaundice, first we do LFT and then we do ultrasound. Ultrasound will tell us something that there is some problem in the biliary channels, And to see the biliary channels, we have got three wonderful investigations: ERCP, MRCP, HIDA scan. ERCP is endoscopic retrograde cholangiopancreaticography. MRCP is just an MRI, and HIDA scan is a radioisotope scan, wherein we give hepatobiliary immunodiacetic acid radioisotope. Now, this is a small baby, 10-day-old baby. Generally, MRI would be difficult in small babies. So, we go with other investigations. Now, ERCP also cannot be done in biliary atresia, because in ERCP we have to put the contrast in the common bile duct. But the problem here is whether it is type 1, type 2 or type 3, common bile duct is absent. So we cannot put the contrast in the common bile duct. So ERCP also is not possible in biliary atresia. That is why only option left is a radioisotope scan, HIDA scan, where we inject this isotope in the peripheral vein, and this goes to the circulation, it goes in the liver, we take the pictures with the help of gamma camera, and in a normal individual, this HIDA isotope travels through the biliary channels and it goes into the duodenum within 30 to 60 minutes. If we are doing a HIDA scan in biliary atresia, then it will not be able to go into the duodenum because of traffic jam. So this can even show the type of biliary atresia, whether only CBD is absent or CBD CHD are absent or CBD CHD right left hepatic ducts are absent. That is why the investigation of choice for biliary atresia is not MRCP, not ERCP, but HIDA scan. In the treatment, in type 1, if only CBD is not there, then we connect the common hepatic duct with the jejunum. And this is making a Y type of configuration. We actually transected the jejunum from here and we took this jejunum here, connected with the common hepatic duct. It is going down, and then this jejunum was again connected with this jejunum. So this is jejunosteomy. The food is coming from here, pancreatic juice is coming from here. Now when the food comes in this area, pancreatic juice is also coming here and bile will be coming from here. So the food will be digested properly. This is a Roux-en-Y hepaticojejunostomy. In type 2 and type 3 biliary atresias, the problem is, suppose it is type 3 and there are no biliary channels. Then we connect the jejunum directly into the liver at the porta hepatis. That is hepatico-portoenterostomy. This is Kasai operation. Kasai operation. But the problem in Kasai operation is there is a possibility that in few months, maybe 6 months, 1 year, 2 years, if this jejunum is not able to drain complete bile from the liver, there will be bile congestion in the liver which might be causing damage to the hepatocytes, and eventually if the entire liver fails, then we are left with no option but we have to do a liver transplant. Another pathology here is choledochal cyst. Chole means bile, doco means duct. Choledochal cyst is cystic dilatation in the biliary channels. Again, nobody knows what is the exact reason, but probably there is a problem in the junction of the bile duct with the pancreatic duct, which is causing abnormal dilatation in the biliary channels. Todani classified them into 5 types, and Todani said if there is dilatation which is involving only the CBD, then it can be type 1, type 2, type 3. But if this dilatation is involving the hepatic ducts also, then it can be type 4 or type 5. In type 1, which is the most common, there is diffuse dilatation of the CBD. In type 2, there is eccentric dilatation or diverticle of CBD above the pancreas. In type 3, there is dilatation of CBD within the pancreas, which can even project into the duodenum, that is called as choledococele. Type 4 can be divided into A and B. A, where extrahepatic as well as intrahepatic cystic dilatations are there. 4B, only extrahepatic cystic dilatations, and 5, only intrahepatic cystic dilatations. This type 5 is also called as Caroli's disease. And in Caroli's disease, when we are doing ultrasound, we find a central white shadow, that is central dot sign. This corresponds to portal vein. Now, how to approach these patients, that depends on the presentation of choledochal cyst. This game can present either in the OPD or in the emergency. In the OPD, the patient, the baby may have intermittent jaundice, that is painless intermittent jaundice in infancy, or there can be mass in the right hypochondrium. If baby presents with jaundice, first we'll do LFT and then we do ultrasound. If baby presents with mass, first we do ultrasound, and if there is any problem in the biliary channels on ultrasound, we do LFT. To see the biliary channels, MRCP and ERCP would be the best. If suppose the baby is a little old, maybe more than 2 years of age, we prefer doing MRCP. But in small babies, their doing an MRI would be difficult, so we prefer doing ERCP. Once the diagnosis is made, like this is the ultrasound versus ERCP picture. On ultrasound, this is the gallbladder and this is the bile duct. In the bile duct, we are seeing this abnormal dilatation. And then below this is the portal vein. On ERCP, this is the endoscope, and here we push the contrast and we can see a nice choledochal cyst here. This cyst sometimes can complicate because of stasis. There can be party, that is party in the bile duct, cholangitis can occur, party in or infection in biliary, urinary, salivary channels can lead to stone formation. So choledocholithiasis can occur, or if the cyst persists for a long period of time, cancer can occur in the bile duct, that is cholangiocarcinoma. The commonest site of cholangiocarcinoma is the confluence of right and left hepatic ducts, that is also the hilum. So we can call this as hilar cholangiocarcinoma or Klatskin's tumor. Because this choledochal cyst can complicate into cholangitis, choledocholithiasis, cholangiocarcinoma, if cancer can occur in choledochal cyst, then we should always remove these choledochal cyst excision. That means if you are talking about type 1, which is diffuse dilatation of CBD, if you remove the entire CBD, you have to connect the common hepatic duct with the jejunum. So cyst excision with hepatico-jejunostomy would be the correct answer. If this cyst complicate to cholangitis, that means there is significant bacterial party going on in the bile duct. Remember, bile duct party is not a small party. Party whole night, DJ, bang, 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 bang. E. coli, Klebsiellas, they are causing anaerobes, they are causing all this party. And this is causing acute inflammation, Reber tumor, Calor, dollar in this bile duct. Now, patient will present with sudden onset of pain in the right hypochondrium, high-grade fever, chills and rigors, and jaundice. Pain, fever, jaundice is Charcot's triad. Pain, fever, jaundice, Charcot's. Pain, fever, jaundice, Charcot's. If this party goes into the blood, then this party can go to all parts of the body and patient will develop septicemia. Patient can go into septic shock where hypoperfusion of tissues, less oxygen supply to the tissues. Here there would be less pressure in the pipeline, suppose, so less oxygen going into the tissues. That means hypotension, and because oxygen is not reaching to the brain, there can be mental confusion. Pain, fever, jaundice plus hypotension and mental confusion. This is called as Raynaud's pentad. If the patient is in shock, पैथोलॉजी कैन बी एनी, समस्या कोई भी हो, अगर पेशेंट शॉक में है तो सबसे पहले हमारा फोकस उसकी जिंदगी बचाने पे होता है. द फर्स्ट फोकस इज टू सेव द लाइफ. To save the life, if the pressure in the pipeline is less, you give IV fluids. Patient is having fever, you give IV antibiotics. Try to generate pressure in the pipeline with IV fluids. Try to control the bacterial party with IV antibiotics. Once the patient becomes a bit stable, which may take 4 to 6 or 8 hours, then do a quick LFT ultrasound. And if you know that there is a big party going on in the biliary channels, then whatever IV antibiotic you are giving, the dose of that IV antibiotic may not be sufficient enough to take control of such a big party in the bile duct. That means you have to remove the septic load from the CBD to save the life. Otherwise, patient will die of septicemia. To drain that septic load, to drain the bacterial party from the CBD, a simple procedure can be you do the endoscopy and you put a stent into the CBD. That is ERCP and stenting. This is endobiliary stenting. This is how the stenting can be done. And here you see, this is the stent which you are seeing inside the duodenum. And this is the X-ray picture which is showing the stent in the common bile duct. If the stent would have been in the pancreatic duct, the stent would have seen like this. If the stent is in the ureter, then it would have been seen something like this, double J stent. Right? So depending on the location of the stent, we can get some idea about the placement location. This endobiliary stenting will drain the party from the CBD and will help in saving the life of this patient. Once the life of this patient is saved, then maybe after 1 month, 2 months time, when the patient becomes absolutely stable, you know the definitive treatment for choledochal cyst will be cyst excision and hepaticojejunostomy. But this is something which we will not do in emergency where the patient was dying of septicemia. We are trying to do minimal intervention at the time when the patient is dying. Intervention which has to save the life of this patient, right? And then once the patient becomes stable, then we'll be doing the definitive treatment. All the great doctors of this country, please remember this concept in all 19 subjects. Depending on how the patient is coming to you, your approach will change accordingly. If the patient is in shock, first you have to save the life of this patient. If there is huge amount of bacterial load, the first priority is to reduce the septic load to save the life. And once the situation comes under control, for which you might have to wait maybe for a few weeks or maybe few months, let the patient settle down completely. Then it would be wiser to do a definitive surgery in that particular patient. Right. And this applies for all surgical emergencies. Okay. Now, in the right hypochondrium, another story is intussusception. Intussusception is telescoping or invagination of one portion of the intestine into the adjacent part. Like here, this is cecum because we can see the tubular appendix here. So this will be ileum. So this is ileocolic intussusception. Ileocolic, or we can say it as ileocecal. Why this intussusception occurs? Nobody knows the exact reasons. Again, there are many hypotheses. Conceptually, what we can understand is whenever some portion of the intestine becomes heavy, then peristalsis can force that heavy part of the intestine to ride into the adjacent part. Most often, this intussusception occurs at around 6 months of age, though the range can be 5 to 10 months. Reasons of intussusception can be many. For example, rotavirus infection, rotavirus vaccination, Pierce patches involution, Pierce patches hypertrophy, Meckel's diverticulum. These are some common causes in children. However, in case of adults, it is not the ileocolic intussusception which is the most common. It is the colocolic intussusception which is the most common. And that is because of polyps developing in the colon. Now, in this intussusception, let us imagine the story of a small 6-7 months old baby. If the ileum has gone into the cecum, then agreed that ileum and cecum, they are located in the right iliac fossa area. So ideally we should have seen something in the right iliac fossa. But what happens when the ileum has gone into the cecum and it is forming a lump type of thing, then with the peristaltic movements, this lump move upwards and it goes to the right hypochondrium. And by the time baby presents to us, the lump is not in the right iliac, but it is in the right hypochondrium. It's a sausage-shaped lump in the right hypochondrium, or sometimes in the left paraumbilical region. The concavity of this lump is directed towards the umbilicus. Because the ileum has gone into the cecum, there might be some injury and the baby may be passing blood and mucus in stool. That is red currant jelly stool. Right? This is basically like the ice cream red currant jelly, or if you are putting red colored jam on the bread. So that red currant jelly stool is what we see. When we clinically examine these babies and we palpate the right iliac fossa, there is emptiness in the right iliac fossa which is called as sign of dance. ऐसा लगता है इस इलाके में पहले कोई रहा करता था, अब अपना घर छोड़ के चला गया है. This emptiness, a khalipan in the right iliac fossa, is sign of dance. And when we do digital rectal examination in this baby, the examiner's finger will be stained with blood. So these are some key words commonly used by the examiner: sausage lump, red currant jelly stool, and sign of dance. If there is a lump in the abdomen, then how we have to approach this baby? This may be brought to us in the emergency. We can do an ultrasound in this baby if there is abdominal mass lump, which can show us a donut sign, or we also call it as target sign. If we are doing X-ray, then on X-ray we can find a crescent sign or a meniscus sign. Crescent sign or meniscus sign. When we are doing barium enema, then we see this beautiful claw sign. Beautiful claw sign. We can also see a coiled spring sign. Now this claw sign and coiled spring sign, if the ileum is tightly fitted in the cecum and you are giving barium enema from below, the contrast will get holded in the cecum only and nothing will be going down. This is going to produce a claw. However, if the ileum is fitted loosely into the cecum, then when you are giving the contrast from below, the contrast will be flowing around the ileum and it will be forming coils like coil in a spring. That is coiled spring sign. Best for the intestines in general is CECT. In the treatment for intussusception, we want the inner tube to reduce. And to reduce the inner tube, hydrostatic reduction would be the best. Like we can give something with pressure from below, and when it is going with pressure, it can force the inner tube to come out, like we are seeing here. We can use air, saline, or barium. Air causes minimal injury, so air enema is preferred. If hydrostatic reduction fails, then we have to do operative reduction, where we gently push, gentle milking of the outer tube to reduce the inner tube. We never pull in intussusception. If by chance this has become gangrenous, then we have to do resection and anastomosis. Right, resection and anastomosis. If we move to the lumbar region, ectopic kidney, polycystic kidney, and horseshoe kidney. Ectopic kidney, most often it is located in the pelvic area, in the retroperitoneum, and usually on the left side. Polycystic kidney disease, when there are multiple cysts in the kidney, this can be congenital, it can be infantile. Congenital is much more common, also called as adult polycystic kidney. Why also called as adult? Because it does not usually manifest early in life. The age of the patient is more than 30-35 years at the time of presentation. Though it is congenital, but because it presents after 30 years of age, we call it as adult polycystic kidney disease. This congenital or adult polycystic kidney disease is autosomal dominant. However, infantile polycystic kidney disease, which is rare, this is autosomal recessive and it has very high mortality as well. Now, congenital or adult polycystic kidney disease, it is bilateral. It is associated with cysts in other organs like liver, spleen, pancreas, ovaries. This can be associated with mitral valve prolapse and perianeurysm of circle of Willis. And as we discussed, it clinically presents after 30 years of age. This polycystic kidney disease most often presents with hypertension, 75% of patients, and it is often gene related. Because of multiple cysts in both the kidneys, there can be swelling and pain in both the lumbar region. There can be hematuria, there can be uremia because the cysts are pressing the nephrons. How to approach these patients? If patient present with swelling in the lumbar region, we do a ultrasound which can show us multiple cysts in both the kidneys. But if we also want to see the functional status of the kidney, we can do a CECT or we can do some IVP types. When we are doing a contrast study, whether CECT or IVP, because of compression by the cyst on the calyces are thinned out. These thinned out calyces, what you are seeing, this is looking like a spider leg appearance. So this is a spider leg appearance seen in polycystic kidney disease. In the treatment, basically, initially we can try doing a deroofing of the cyst to release the pressure on the nephrons, but eventually the treatment is kidney transplant. And whenever we are doing kidney transplants, generally we prefer left kidney from the donor because of long left renal vein. And this transplanted kidney is placed in the iliac fossa, usually the right iliac fossa, Such type of transplants where the transplanted organ is not placed in the same anatomical location but placed in the different anatomical location are heterotopic transplants. However, when we are putting the transplanted organ in the same anatomical location like liver, that is called as orthotopic transplant. Now, these are some images which are showing us the difference between X-ray of kidney, ureter, bladder and intravenous pyelography. Like the first picture, this is plain X-ray of kidney, ureter and bladder. In this, you are not seeing any contrast anywhere. You are just seeing some abnormality in the kidney here. If I focus, this looks to be a big stone inside the kidney. This is on plain film. But if you are giving the contrast, now here you can see that the contrast is filling the pelvic calyceal system, and then this contrast is coming down in the ureter. And you cannot see the entire ureter in one X-ray because ureter has got peristaltic movements. So probably due to movements, you cannot see the entire length of ureter in one X-ray. So if you are able to see the contrast, this is IVP or IVU. There are various investigations which we can do for the urinary tract as far as contrast studies are concerned. For example, we can divide the urinary tract into upper and lower. Upper tract means kidney, ureter, lower tract means bladder and urethra. For kidney ureter, the best contrast study would be IVP. In this, we give the contrast intravenously. It travels through the circulation to the kidney and it is filtered by the nephrons, and we see the excretion of this contrast through the ureter. So we can see the contrast flowing like this into the bladder. This is IVP. If IVP cannot be done and we want to study this area, we can pass a cystoscope into the bladder, then pass a ureteric catheter through the cystoscope into the ureter, and then push the contrast. The contrast will be going like this, and we take the X-ray. This is retrograde pyelography. If retrograde pyelography also cannot be done, then we can do a percutaneous puncture the skin and put some needle into the pelvic calyceal system and give the contrast here. So now this contrast will be traveling from above downwards. This is antegrade pyelography. To study the lower tract, if we have to study the urinary bladder, we can simply put a catheter into the bladder and give the contrast and take the X-ray. This is cystogram or cystography. If we have to study the urethra, we can put a catheter into the urethra for this much distance and then give the contrast. The contrast will be moving up like this and we take the X-ray. This is retrograde urethrogram. One micturating cystourethrogram or voiding cystogram is required in two pathologies. In voiding cystogram or micturating cystourethrogram, we fill the bladder with the contrast first, then ask the patient to micturate, and then the contrast will be traveling from the bladder. If there are posterior urethral valves, the contrast will be holded up like this and we can see these posterior urethral valves. If there is vesicoureteric reflux and we ask the patient to micturate, the contrast will start traveling from the bladder towards the ureter, showing the vesicoureteric reflux. So for posterior urethral valves and vesicoureteric reflux, we can do micturating cystourethrogram or voiding cystogram. If we look at the contrast studies of GIT, then to study the esophagus, we are doing barium swallow. To study the stomach, we are doing a barium meal. And to study the duodenum, jejunum, ileum, that is small intestine, we are doing a barium meal follow through. However, for the colon, we are doing barium enema. Right. Then horseshoe kidney, the incidence of horseshoe kidney is 1 in 900. And this is basically a pair of ectopic kidney due to fusion of medial subdivision of lower poles of both the kidneys. And the ascent is impeded by the inferior mesenteric artery. Generally, the site of fusion or isthmus, which was earlier thought to be L3, L4, now it is L4, L5, where L4 is a better answer. And this is how the horseshoe kidney looks like. This is a CT scan. As we can see, the bone is appearing white, and this is the horseshoe kidney. Another image, this is also a CT scan as the bone is appearing white. So this is a horseshoe kidney. Right. Now, generally patient does not have any problems. Nothing has to be done if patient is asymptomatic, but sometimes there is a possibility that the isthmus here may put pressure on these ureters and there is ureteral compression, because of which the proximal pupil will get dilated. Proximal hydronephrosis type of story. And when we are doing IVP or IVU, herein we can find a flower vase appearance or flower vase ureters. This is a hand joining sign. Hand joining sign. Now, in the treatment, generally the patient does not have any problem, nothing has to be done, but if the patient is having any symptoms or complications, like if there are stones, then we have to remove the stones. If there is infection, we have to treat with antibiotics. Division of isthmus and separating both the kidneys is not the treatment of choice, because three solid organs in the abdomen, liver, spleen, kidney, they are full of blood. Whenever we are making any incision on these liver, spleen, kidney, or there is any abdominal trauma, there are chances of huge amount of bleeding. So unless and until it is very important, we avoid making incisions on the parenchyma of liver, spleen, and kidney. Right. Most common cause of abdominal mass in a newborn baby is hydronephrosis, that is due to pelvic-ureteric junction obstruction. However, second most common cause of abdominal mass in a newborn baby is multicystic kidney disease. Right. Now, if we look at the Meckel's diverticulum story, during intrauterine life, there is a connection of the umbilicus with the intestines through a vitellointestinal duct or the omphallomesenteric duct. And there is a connection of the umbilicus with the urinary bladder through this allantois. Generally after birth, these connections, they obliterate. But if these connections remain patent, that means there will be abnormal connection between two people, that is a fistula. If vitellointestinal duct remains patent, intestinal contents, that is fecal matter, come out through the umbilicus of the newborn baby. This is umbilical fecal fistula. If watery discharge or urine comes out of the umbilicus of the baby, newborn baby, this is a umbilical urinary fistula. Sometimes there may be just a sinus. For example, if the intestinal end or the vesical end closes, but only the umbilical end persist, then this is a one-sided connection with the skin, and one-sided connection with the skin is called as sinus. Only mucus will come out through the umbilicus of this baby in umbilical sinus. Another story can be if only the organ part persists and the umbilical end has closed. Now this is a one-sided connection with the organ, and this is a diverticula. This is Meckel's diverticula. This is congenital bladder diverticula. Both are congenital, that means present since birth. And congenital diverticulas are true diverticulas because they contain all the layers. false diverticulars, acquired which are acquired later in life. जैसे जैसे उम्र बढ़ती है इमारतें कमज़ोर होती हैं. As we grow older, the tissues become weaker and weaker. Whenever there is any traffic jam type of situation anywhere in the body, the proximal people will dilate, pressure in the proximal part will increase, and high pressure in the proximal part can force the mucosa and submucosa of the proximal part to protrude through the muscle layer and go outwards, leading to that acquired false diverticula. As it does not contain all the layers, it contains only mucosa and superficial submucosa, and they're usually seen in elderly people. Now, Meckel's diverticulum, this is actually the persistence of the intestinal end of the vitellointestinal duct. This is a congenital diverticula, true diverticula, because it contains all the layers of the intestine. It is located on the anti-mesenteric border, not on the mesenteric border. It is on the anti-mesenteric border. It has its own blood supply and it follows the rule of 2. That is, it is present in 2% of population. It is 2 centimeter wide, 2 inches long, and it is located 2 feet, that is 60 centimeter proximal to ileocecal junction. 2% of patients can be symptomatic, presents at around 2 years of age. It consists of heterotopic epithelium, most commonly gastric. However, pancreatic colonic lining can also be present. If this Meckel's goes into the inguinal hernia sac, we call such hernia as Litters hernia. If by chance the patient is symptomatic, then generally it mimics acute appendicitis. Very rarely complications can occur in Meckel's like bleeding, maybe diverticulitis, diverticular perforation, maybe peptic ulceration because of gastric lining and Meckel's, maybe intussusception because Meckel's will make that portion of the intestine heavy and peristalsis can force this part to move into the adjacent part. And surprisingly, Meckel's sometimes can even cause intestinal obstructions. The reason for intestinal obstruction is not Meckel's, but because a band may persist from the umbilicus to the apex of Meckel's, around which the intestines can rotate. So reason for intestinal obstruction is not Meckel's, but it is the band. The best investigation to see Meckel's is a Meckel's scan, that is a radioisotope scan, technetium per technetate scan. In this, if there is gastric lining, then this scan gives a black shadow at the area of gastric lining. So if you find this black shadow in the lower abdomen, it is suggestive of Meckel's in the lower abdomen. Though we can do a CCT, double balloon enteroscopy, video capsule endoscopy, barium meal follow-throughs, enteroclysis, all those investigations can be done. But best would be Meckel's scan. As far as treatment is concerned, then because majority patients are asymptomatic, so nothing has to be done. But if the patient is having any symptoms or complications, then depending on if it's a narrow mouth Meckel's, then we can simply do diverticulectomy. But if it is a wide mouth Meckel's, then we have to do resection of segment of intestine bearing the Meckel's and anastomosis. For Meckel's surgery, we are commonly using a linear stapler. If found incidentally at operation for some other disease, we can just make a small note also. If found incidentally at operation for some other disease, then the guideline says if it is narrow mouth, that means the chances of complications would be high. So you can chop this diverticula, though at this point of time it was not causing any problems. But if it is wide mouth, then the chances of complication in Meikles would be less. So you can leave it as such also. Leave as such also. Right. The left iliac fossa, Hirschsprung disease. Hirschsprung disease is also called as congenital megacolon or congenital aganglionosis. This is basically absence of ganglion cells in the nerve plexus due to failure of migration of neural crest cells. Most commonly, it affects the rectosigmoid area where rectum is always involved. Now, this presentation can be depending on whether a short segment or a long segment is aganglionic. For example, if only a short segment is aganglionic, then this story will not present in a newborn baby. But as the baby grows, then the baby may suffer from frequent constipation. There may be delay in passage of the fecal matter. And when we take the history, we also come to know that even after birth, there was delayed passage of meconium even after birth. Now, if we are suspecting Hirschsprung, then first thing what we can do is barium enema. And on barium enema, the aganglionic or the pathological segment appears narrow and contracted, while the proximal normal segment looks to be dilated. So just by identifying whether only a short segment is narrow contracted or a long segment is narrow contracted, we can determine the extent of disease. To know the severity of obstruction, we can do a manometry. Depending on the severity of obstruction, the pressure in the proximal area will also be high accordingly. However, to conclude the diagnosis, the investigation of choice to make the diagnosis of Hirschsprung disease would be suction rectal biopsy. And once the diagnosis is made for treatment, we can do Duhamel, Swenson, and Sove coloanal anastomosis. However, if it is affecting a long segment, if long segment is aganglionic, then the story will present in the newborn baby because after birth, the baby meconium, the peristalsis here may not be sufficient to make this meconium pass through such a big aganglionic segment. So all the meconium is going to get impacted here, which may create a complete traffic jam type of situation, causing all the proximal intestine to dilate. And this will cause gross abdominal distension in the baby. Because there is a risk that the proximal colon is grossly distended and it can rupture inside the peritoneal cavity, which will cause leakage of fecal matter in the peritoneal cavity, causing fecal potty peritonitis, which can lead to septicemia and death of the patient. So it is better that before the colon ruptures inside the peritoneal cavity, you can make a small cut on the abdominal wall, maybe under local anesthesia, put your fingers inside and just pick that dilated transverse colon out on the abdominal wall and do a proximal colostomy. So you just open the transverse colon outside the abdomen and the potty will come outside the abdomen. No potty inside the abdomen, no peritonitis, no septicemia, no death of this baby. Remember, my dear friends, whenever there is a complete traffic jam situation in various areas of the body, like here, if it is a large intestinal obstruction, the reason for intestinal obstruction can be any, कारण कुछ भी हो सकता है. अगर रास्ता पूरी तरह से जाम है और प्रॉक्सिमल कहानी डायलेटेड है, प्रॉक्सिमल प्रेशर ज़्यादा है, कभी भी प्रॉक्सिमल कहानी फट सकती है. Anytime, because of high pressure, the proximal part can rupture. Before it ruptures in the abdomen, do a proximal colostomy. and remove all that fecal matter outside, not inside. By chance, if suppose the colon would have ruptured inside the peritoneal cavity and the patient would be having peritonitis, septicemia, then first you have to save the life, IV fluids, IV antibiotics, make the patient stable, and then you have to remove this big bacterial load from the peritoneal cavity, and for that you will do laparotomy and a nice peritoneal lavage. झाड़ू पोछा लगाना है अच्छे से, स्वच्छ भारत अभियान मोदी जी का, right? So depending on how the game is being played, if we keep on creating nice concepts inside our brains, then the life becomes easy to answer these conceptual questions, right? Okay. Another story now in the hypogastric area, duplication of renal pelvis and ureter. This is the commonest congenital anomaly of the upper urinary tract, where in one kidney, instead of one renal pelvis and one ureter, there may be two renal pelvis and there may be two ureters as well. Duplication of renal pelvis, generally the upper pelvis is small and the lower pelvis is large. And in such cases, we find there is a pelvic-ureteric junction obstruction, especially in the upper pelvis, because of which the upper pelvis dilates and enlarges and start putting pressure on the lower pelvis, because of which the lower pelvis droops down. So this is drooping lily sign. Drooping lily sign. Right. This is in duplication of renal pelvis. Water lily sign is seen in hydatid cyst. If there is duplication of ureter, it follows a Mayer-Wegert law. And that says if there are two ureters, generally the two ureters, they will join with each other so that there is only one ureter which is going down and it is opening in the bladder. But sometimes the two ureters may not join and these two ureters may be opening separately. In such cases, the lower ureter may be opening normally, but the upper ureter may pass distally and open more medially than its counterpart. In case of boys, the ectopic ureter most often opens at the apex of trigone. However, it can open in the ejaculatory duct, maybe in the seminal vesicles, maybe in the posterior urethra, or rarely in the anterior urethra, where the boy may present with recurrent UTI. However, in case of girls, this ectopic ureter opens distal to the distal sphincter. And if it is opening distal to the distal sphincter, then there will be continuous dribbling of urine. So a girl, 3-year-old, who is having normal bladder filling sensation, plus she is able to pass urine normally, plus if she is having continuous dribbling of urine or dribbling urinary incontinence, then the most likely pathology is ectopic ureter. We can do IVP, IVU to see these ectopic ureters. However, CECT would be the best. In the treatment, we have to just put that ectopic ureter back into the bladder. That is ureteric reimplantation. Retrocaval ureter. Retrocaval ureter is normally the right ureter is on the right side of inferior vena cava. But sometimes, because of the abnormality related to the inferior vena cava, the cardinal vein, what can happen? This ureter may loop around the right ureter. This ureter may loop around the right ureter. This ureter may loop around the inferior vena cava. And then this inferior vena cava may compress the right ureter, leading to proximal dilatation and right-sided unilateral hydronephrosis. When we do a IVP or IVU, we can find a reverse J sign or a fish hook sign. Fish hook sign. Now, this is generally seen at the level of L3, L4. If the patient is having any problems, maybe because of hydronephrosis, there may be UTI stones, then we can do uretroplasty. We can chop the urethra above and below and join both of them. Or we might have to do a pyeloplasty where we are doing reconstruction of the renal pelvis. Uretroceal. Uretroceal, this is basically partial atresia of the ureteric orifice. It is common in females in childhood. If there is a traffic jam at the ureteric orifice, the proximal pupil will get dilated. There may be stasis party, recurrent UTIs can occur. And when we are doing IVP, IVU, when the contrast is coming here, there will be holding of the contrast in this area, and then the proximal muscles are going to contract forcefully and they'll try to throw the urine out. As soon as the urine goes out, this looks like the cobra is taking the tongue out. This is cobra head or adder head appearance. This time we had bilateral uretroceal as the image-based question. Right. In the treatment, we ideally should surgically excise this uretroceal and do a ureteric re-implantation. Earlier, we were doing endoscopic longitudinal incision of the ureteric orifice, but it used to cause vesico-ureteric reflux. Now, if we go down into the urethra, the hypospadias and the posterior urethral valves. Posterior urethral valves, they are the folds of urothelium, or we can say the flap of urothelium present just distal to verumontanum within the prostatic urethra only in boys. This is actually the most common cause of urethral obstruction in boys. Now, depending on whether these valves are incomplete or whether these valves are complete. If they are incomplete, then the story presents in childhood with recurrent UTI. And for this we do micturating cystourethrogram. As we can see, on contraction of the bladder, the contrast is moving down and we can see a dilated posterior urethra, and here we can see the site of posterior urethral valve. In the treatment, we pass an endoscope, that is cystoscope, and we do fulgurate these valves, burn these valves. That is endoscopic fulguration of the valves or transurethral fulguration of these valves. However, if the valves are complete, then there is a complete traffic jam. In the newborn baby, the urine will not be going out. So there will be retention of urine, and in these cases, to relieve this retention, we do a suprapubic cystostomy. Suprapubic cystostomy. Right. January 26. Okay. Whittaker test. Whittaker test is done in hydronephrosis, where we compare the pressure in the kidney and the bladder to identify what is the cause of hydronephrosis, whether ureteric problem or urethral problem. If it is a ureteric obstruction causing hydronephrosis, only kidney pressure will be high, bladder pressure will be normal. But if it is a urethral obstruction, then bladder pressure will also be high and kidney pressure will also be high. So we come to know who is responsible for hydronephrosis through Whittaker test. This is another micturating cystourethrogram where you can see this bladder, you can see the posterior urethra, and you can see the site of traffic jam. Hypospadias is when the external urethral opening is not present at the tip of the glans, but it is present anywhere on the undersurface of penis, and we can classify them into glandular, coronal, distal penile, mid penile, proximal penile, penoscrotal, scrotal, and perineal type. Opening which is more close to the normal will be more common and less severe. So glandular is the most common, least severe type, and it does not require any treatment also. However, perineal will be the least common but the most severe type, and in perineal hypospadias, sometimes the sex is difficult to differentiate as well. Now, this hypospadias is actually the most common congenital anomaly of male urethra. 1 in 300 male live births. It has been seen that during pregnancy, if the mother had taken diethylstilbestrol, then the chances of hypospadias in the baby would be high. In hypospadias, because of absence of urethra distal to the ectopic opening, there is a fibrous cord which causes curvature of the penis. In hypospadias, there is ventral curvature or ventral chordae, plus the meatal opening is narrow, that is meatal stenosis. Now, if this is the problem, ideally the urine should have come out like this. That means this urethra should have been like this, and the urine should have been going like this. But in hypospadias, there is chordae, downward curvature, plus there is meatal stenosis. So the urine is coming like this. When the baby will grow later in life, he will not be having proper erection. He won't be able to deposit sperms in the vagina, which are serious issues. So we need to correct this pathology. We have to do a chordae correction, make the penis straight, and do a urethral reconstruction, that is urethroplasty. This is done at around 10 months of age, 6 to 18 months, and we use prepuce for making the new urethra. Because prepuce is used for making new urethra, so circumcision is contraindicated even in a Muslim or a Jew baby if he has hypospadias. The complication of this urethral reconstruction, because the sutures can become wet and they can break, so urine may start leaking and may create a hole in the skin, and urine may start coming out through the hole in the skin. That means abnormal relation can develop between the skin and the urethra, that is ureterocutaneous fistula can occur as a complication of hypospadia surgery. Then undescended testis or cryptorchidism. We know that the testes follow a defined path of descent and they reach to the bottom of the scrotum just before birth. But if the testes are arrested anywhere in the normal path of descent, undescended, if the testes deviate from the normal path, go somewhere else, ectopic. If the testes start developing in intrauterine life but disappear before birth, vanishing. If the testis has normally descended into the scrotum, but if there is contraction of the cremasteric muscle, the testis ascend upwards into the inguinal canal. But if on clinical examination, these testes can be brought by manual manipulation to the bottom of the scrotum in the OPD, then they are not called undescended, they are retractile. And retractile testis does not require any treatment. अगर टेस्टिस अपने रास्ते में कहीं अटक गई, अनडिसेंडेड, भटक गई, एक्टोपिक, गायब हो गई, वैनिशिंग, उचक गई, रिट्रैक्टाइल. Undescended testis is the most common congenital anomaly of male genitalia, and the incidence is 3% in a full-term baby at birth. However, if the baby is born preterm, then the incidence is 30%. Right-sided 50%, left-sided 30%, bilateral 20%. 75% of these undescended testes, they descend down to the bottom of the scrotum within first 3 months of life. Undescended testes, most common site is high up in the scrotum. Second most common site is the inguinal canal. Ectopic testis, most common site is the superficial inguinal pouch or the Dennis Brown pouch. However, they can be located in the femoral triangle root of the penis or in the perineum. Histological changes of undescended testes, they start appearing after 1 year of age. And the complications which can occur in undescended testes are remembered by the mnemonic A testis. A for atrophy, T for trauma, E for epididymoarthritis, S for sterility if both the testes are undescended. Then both the testes are intra-abdominal, where the intra-abdominal temperature is higher by 2 degrees centigrade, which can interfere with spermatogenesis. But if one testis has gone down into the scrotum already, then one sperm is sufficient to produce that fertility. One testis is a big thing. एक हीरा काफी है fertility के लिए. So if they are saying sterility, it means both the testes should be undescended. There can be torsion, there can be inguinal hernia, which is the most common, and seminoma is a common complication as well. Actually, the commonest cause of testicular cancer is undescended testes. Now, how to approach these babies? Clinical examination is very important, inspection and palpation, and many times we are able to feel these undescended testes on palpation. We can confirm by ultrasound also. But if we are not able to feel the testes on clinical examination, plus we are not able to locate the testes on ultrasound as well, then the gold standard investigation for non-palpable testes would be diagnostic laparoscopy. And we figure out where this undescended testes are, and then the treatment should be, we have to bring this undescended testes down to the bottom of the scrotum and fix to the bottom of the scrotum. That is orchidopexy, which is done between 6 to 18 months of age. However, if 6 to 18 months is not there in the option, then you mark the answer as 6 to 12 months. 6 to 12 months. Now, another story is imperforate anus. Normally, we know there is a nice opening here. But if somebody has done bad deeds in his previous life, then God may say that I will not make this opening. Only the opening may be absent, or maybe the anal canal is also absent, or maybe the rectum is also absent. So how do we come to know whether it's a low anomaly or a high anomaly? We can do an X-ray of the baby. Earlier, we used to invert the baby. We used to make the baby upside down. That means sar niche or tange upar, head down and the legs up. Gas always rises up after 24 hours of birth. We used to do this. We used to put a marker at the potential site of anal opening and then used to take the X-ray. Gas will rise up and then we see what is the distance between the last gas shadow and the marker. Based on that, we used to identify whether it is just a low anomaly or it is a high anomaly. But now they say there is no need to turn the baby upside down. You can just make the baby lie in the prone position and take a lateral X-ray and then see what is the distance between the last gas shadow and the marker. Based on this, we can decide whether it's low or high. If it is just a low, we do anoplasty. If it is a high, we have to do anorectoplasty. That is posterior sagittal anorectoplasty. Now, this is the revision what we have done with the workbook. We'll also revise it quickly without the workbook now, wherein I'll be coming on the big screen. I'll be closing the eyes, and maybe in 40 minutes, we should be able to revise the entire pediatric surgery. Now, why this is going to be important? I'll keep this in the application for all of you till your exam. I'll request the team, the academic team, if they can do this, so that whenever you want to revise pediatric surgery, suppose, then maybe when you're lying on the bed and suppose you just want to listen, you don't want to see, you just put the earphones in your ears and you are listening to this as a podcast, right? Okay. Now, we'll start the pediatric surgery from top to bottom, from the face, cleft lip palate, Then the neck, thyroglossal cyst, branchial fistula, cystic hygroma, thorax, esophageal atresia, dysphagia, lusoria, abdomen, epigastrium, duodenal atresia, annular pancreas, hypertrophic pyloric stenosis, right hypochondrium, biliary atresia, choledochal cyst, intussusception, lumbar region, ectopic kidney, polycystic kidney, horseshoe kidney, right iliac fossa, Meckel's diverticulum, left iliac fossa, Hirschsprung disease, hypogastrium, duplication of renal pelvis and ureter, retrocaval ureter, uretrocele, in the urethra, posterior urethral valves, hypospadias, in the scrotum, undescended testis, and then at the back, imperforate anus. In the face, the cleft lip palate story, the most common congenital anomaly of the orofacial structure is combined cleft lip and palate 45%, cleft palate alone 40%, cleft lip alone 15%, where left-sided cleft lips are more common. If the cleft of the lip is not going inside the nose, it is partial. If the cleft is going inside the nose, it is complete. If the cleft in the palate remains attached with the vomer-nasal septum, it is incomplete. If the cleft in the palate and the palate is separated from the vomer-nasal septum, it is complete cleft palate. Risk factors can be genetic, family history, environmental factors like maternal epilepsy. If the mother during pregnancy is taking anti-epileptics like phenytoin, diazepam, steroids, chances of cleft lip palate in the baby are high. It can be associated with congenital heart diseases, can be associated with more than 150 syndromes, which include van der Wood, Stickler, Stringent, Treacher-Collins, Pierre-Robin, Patau syndrome, Down syndrome, Eppert syndrome, and so on. Role of supplementation of folic acid to prevent cleft lip and palate is equivocal. The reason for development of these cleft lip palate is failure of fusion of various facial processes. If only median nasal process fails to unite, there will be cleft of the philtrum and the alveolus. If there is failure of fusion of the median nasal process with the maxillary process, then there is cleft of the nose and the lip. And if there is failure of fusion of the maxillary process, that means that two palatine shells cannot fuse and there will be cleft in the palate. Cleft lip can be diagnosed on antenatal ultrasound after 18 weeks of pregnancy. If the baby is born with cleft lip and palate, there can be problems related to airways, swallowing, speech, dentition, feeding, and so on. So we need to do correction for these cleft lip and palate. Algorithm: first 2 months of life, no surgery, focus on feeding, modified feeding bottles, teats, squeeze and suck technique. 3 to 6 months, surgical repair for nose, lip, and the anterior palate, that is the bony part or the front part of the hard palate. The soft palate repair is generally done between 6 to 12 months. In lip reconstruction, muscle reconstruction is the key, not the skin. And in soft palate reconstruction, it is the levator sling that is important, and we call this as intravelar veloplasty. After 1 year of age up to 7 years of age, we focus on feeding, we focus on speech, dentition, aesthetics, where speech is most important at around 1.5 years of age. After 7 years of age, if there is any bony deformity left, we do alveolar bone grafting. Millard's operation generally done for lip reconstruction, Waddell's generally done for palate reconstructions. In the neck, thyroglossal cyst. This is due to persistence of the thyroglossal tract. Even after birth, there may be collection of secretions, most commonly below the hyoid bone, that is subhyoid, seen in children in the midline always, except in the region of Adam's apple, thyroid cartilage, where it is pushed to one side of the midline. These cysts move with deglutition, and a characteristic feature is they also move with protrusion of tongue. Complications which can occur in thyroglossal cyst: infection, abscesses which can rupture, lead to thyroglossal sinus or rarely thyroglossal fistula. Remember, thyroglossal cyst is congenital, but thyroglossal sinus or fistula, they are always acquired. This thyroglossal cyst can even cause papillary thyroid cancer, and the treatment will be cis trunks operation. where we not only remove the thyroglossal cyst, but we also remove the entire thyroglossal tract right up to the foramen cecum on the tongue, wherein we also have to remove the central portion of the hyoid bone. Branchial cyst and branchial fistulas, they are related to second branchial cleft. Cyst is basically remnant of second branchial cleft, and fistula is persistence of the second branchial cleft. Both are located on the anterior border of sternomastoid muscles. Cyst is located slightly higher up at the junction of upper and middle one-third of the neck, while external opening of the fistula is in the lower leg. Internal opening of the fistula is anywhere in the pharynx, most commonly behind the tonsil on the anterior aspect of posterior fascial pillar. However, type 3, type 4 branchial fistula's internal opening is at the pyriform sinus. Cyst is lined by squamous, fistula by ciliated columnar, and the treatment would be excision for both. Cystic hygromas, these are lymphatic swelling in the posterior triangle of neck due to sequestration of jugular lymphatic sacs lined by endothelium. This can present in intrauterine life, and these swellings during intrauterine life sometimes can become very big, which can obstruct labor. 50% of cystic hygromas do present in the neonatal period. Because they contain clear fluid, they are transilluminant. The most brilliantly transilluminant swelling in the body is cystic hygroma. Other swellings which show positive transillumination include annula, hydrocele, meningocele, and rarely branchial cyst. And the treatment for these cystic hygromas would be complete excision. However, alternative treatment option can be injection sclerotherapy, where we give Picibanil OK432. In the thorax, esophageal atresia is absence of some portion of the esophagus due to posterior deviation of the tracheoesophageal septum. We can classify them into different types. Most common is type 3 or type C, where upper esophagus is blind and the lower esophagus is connected to the trachea. The different types can be type 1, where both upper and lower esophagus are blind, type 2 upper esophagus is connected to the trachea, type 3 lower esophagus connected to the trachea, type 4 both upper and lower esophagus connected to trachea, and type 5 no atresia, just a fistula, so it is isolated tracheoesophageal fistula or H type of fistula. Esophageal atresia is associated with various other congenital anomalies remembered by the mnemonic vectorial, vertebral, anorectal, cardiac, tracheoesophageal fistula, renal, limb defects. Most common cardiac defects like VSD, PDA, and tetralogy of Fallot. During intrauterine life, because of esophageal atresia, the saliva will not be going down. It will be coming out from the fetal mouth, adding on to volume of amniotic fluid, polyhydramnios. How this pathology will present? Immediately after birth, you will find continuous frothing or pouring of saliva from the baby's mouth, and there is risk of regurgitation, aspiration, pulmonary complications. In the labor room, you do a bedside test, putting a nasogastric tube. Failure to pass the nasogastric tube beyond 10 centimeters gives you the suspicion of esophageal atresia. You can take the X-ray, where you can find a coiling of nasogastric tube in the upper esophagus. If you find gas in the abdomen, it can be type 3, type 4, type 5. The treatment would be, you have to do a thoracotomy, divide the fistula, and do a esophagostomy. But for doing this, you need to know where is the lower esophagus. So the investigation of choice would be CT scan, where we can use the contrast as well. Now, we do a thoracotomy, divide the fistula, do esophagostomy if the two ends of esophagus were close to each other. But if by chance the two ends of esophagus were far from each other, then instead of operating the baby on first or second day of life, we should wait for 4 to 6 weeks, allow the two ends to grow, and reassess after 4 to 6 weeks. If the two ends have come close, do the esophagostomy. But if the two ends are still far, then you have to do esophageal reconstruction using colon or jejunum or stomach. In the waiting period of 4 to 6 weeks, you do a feeding gastrostomy, or you can do a feeding jejunostomy to give enteral nutrition for such a long period of time. Dysphagia leucoria is compression of the esophagus by aberrant right subclavian artery. Dysphagia can also be caused by other aberrations in the vessel like double aortic arch or right aortic arch, but that is not leukorrhea. In the epigastrium, duodenal atresia is absence of some part of the duodenum due to failure of fusion of the foregut with the midgut. This is the most common cause of intestinal obstruction in a newborn baby. Overall, the most common cause of intestinal obstruction are the postoperative lesions. Duodenal atresia is the most common GI anomaly associated with Down syndrome. Now, in duodenal atresia, because there is a traffic jam distal to the opening of bile duct, so within 4 to 6 hours of birth, the baby presents with bilious vomiting. When we take a X-ray, we find a double bubble sign in all duodenal obstructions. Single bubble sign, pyloric obstruction like infantile hypertrophic pyloric stenosis, double bubble signs in duodenal obstructions like duodenal atresia, annular pancreas, triple bubble sign in jejunal obstructions like jejunal atresia, multiple central air fluid levels in small intestinal obstruction, multiple peripheral air fluid levels in large intestinal obstructions. The treatment of choice for duodenal atresia will be duodeno-duodenostomy. However, alternative treatment can be duodeno-jejunostomy. Annular pancreas is a ring of pancreatic tissue which surrounds the duodenum, can lead to duodenal obstruction, giving double bubble sign on X-ray, and the treatment will be duodeno-duodenostomy, alternative duodeno-jejunostomy, same as duodenal atresia. Hypertrophic pyloric stenosis, the infantile hypertrophic pyloric stenosis. This is idiopathic hypertrophy of the circular muscle fibers of the pylorus, which may take some time. Usually, firstborn male child in the family is affected. Incidence is 2 to 3 per 1,000 live births. The baby usually presents between 2nd to 6th week of life, somewhere around 3rd week of life commonly, as olive lump in the right hypochondrium or epigastrium, which is due to thick pyloric musculature. There may be visible peristalsis moving from left to right after giving test meal to this baby, and this baby will present with projectile non-bilious vomiting. Because gastric contents are coming out, acid is coming out, HCl is coming out, there will be metabolic alkalosis, hypochloremia, and to maintain homeostasis, initially the kidney of this baby will try to throw the alkali out. That means urine would be alkaline. But if the baby is continuously vomiting for 2, 3, 4 days, then baby becomes dehydrated. Volume in the pipeline goes down, pressure in the pipeline goes down, oxygen supply to the vital organs goes down. Baby can die. So the baby's kidney tries to conserve water. Because of radiate stimulation, there will be reabsorption of sodium water from the kidney tubules, and when sodium is getting reabsorbed, then potassium and H ions will be excreted in urine. Potassium in urine, kaliuresis, so this will cause hypokalemia. H ions in urine, that is paradoxical aciduria. Because there was metabolic alkalosis, so ideally the urine should have been alkaline. But because of continuous vomiting, dehydration, baby's first duty is to conserve water. For that, sodium was getting reabsorbed, so potassium H ions got excreted in urine in turn of sodium reabsorption. That is why H ions are going out in urine, which is causing aciduria. Ideally, it should have been alkaluria. But opposite is happening, so we call it as paradoxical aciduria. When this baby comes to us in the emergency, if the baby is dehydrated, if the baby is in shock, the first and foremost duty of the doctor is to save the life. So, to supply oxygen to the vital organs, we have to generate pressure in the pipeline. We have to create volume in the pipeline. So, IV fluids are going to be most crucial. And electrolyte correction has to be done. Make the baby stable. On clinical examination, if you are able to feel that abdominal lump, olive lump, do a ultrasound. Ultrasound of the abdomen is the investigation of choice for hypertrophic pyloric stenosis, where if there is thickness of pyloric muscle more than 3 to 4 millimeter, and length of pyloric canal more than 16 to 17 millimeter, it makes the diagnosis. In the treatment, you want to release the traffic jam. So initially you can try doing a pneumatic balloon dilatation, but this may be temporary only. So a permanent solution would be seromyotomy, that is Ramstead seromyotomy. We do the operation, we cut the serosa muscle at the pylorus and relax the pylorus. Right hypochondrium, biliary atresia, choledochal cyst and intussusception story. Biliary atresia is absence of biliary channels, exact cause is not known but thought to be due to inflammatory fibrosis of the biliary channels starting in the first week of life. Depending on which channel is absent, it is classified into three types. Type 1 only CBD is absent, type 2 CBD CHD are absent, type 3 CBD CHD right left hepatic ducts all are absent. Most common is type 3. If biliary channel is absent, patient will have jaundice, hepatomegaly and steatorrhea presenting either in the later part of first week or in the second week of life. Any patient presenting with jaundice, first investigation is LFT. Then we do ultrasound, which might suggest absence of biliary channels. To see the biliary channels nicely, generally we have three investigations: MRCP, ERCP, and HIDA scan. MRCP is magnetic resonance cholangiopancreatography. ERCP is endoscopic retrograde cholangiopancreatography. And HIDA scan is radioisotope scan, hepatobiliary immunothiacetic acid scan. We are talking about a 10-day-old child in biliary atresia. MRI would be difficult. ERCP would not be possible because in ERCP we have to push the contrast in the CBD, but whether it's type 1, type 2, type 3 biliary atresia, CBD is absent. So ERCP is also not possible. Because MRCP, ERCP is not possible, or because there is a problem in getting MRCP, ERCP done, the only option we have is doing a HIDA scan. And that is why HIDA scan is the investigation of choice, where we can see the excretion of the HIDA isotope in the biliary channels through a gamma camera, and it can even tell us the type of biliary atresia. In the treatment, if it is type 1 biliary atresia, we just connect the common hepatic duct with the jejunum, that is Roux-en-Y hepaticojejunostomy. But in type 2 and type 3, if there are no biliary ducts coming from the liver, we just connect the jejunum in the liver at the porta hepatis, hepatico-porto-enterostomy or Kasai operation. And eventually, after doing a Kasai, there is a possibility that liver gets permanently damaged in 6 months to 2 years time, and then we'll have to do a liver transplant. Choledochal cyst is cystic dilatation of the biliary channels. The exact reason is not known, but probably due to anomalous pancreatico-biliary duct junction, and Tudor classified these choledochal cysts into 5 types. 1, 2, 3 affect the CBD, 4, 5 hepatic ducts. Most common type 1, diffuse dilatation of CBD. Type 2, eccentric dilatation from CBD or diverticular from CBD above the pancreas. Type 3, dilatation of CBD within the pancreas, and it is popping into the duodenum second part, also called as choledococele. Type 4 can be divided into A and B. 4A when there are both extrahepatic as well as intrahepatic cystic dilatations. 4B only extrahepatic duct cystic dilatations. 5 only intrahepatic duct cystic dilatation. Type 5 is also called as Caroli's disease, where we see a central dot sign which corresponds to portal vein. Choledochal cyst can present to us either in the OPD or in emergency. In the OPD, there can be painless intermittent jaundice in infancy, or maybe a mass in the right hypochondrium. If there was jaundice, we do LFT first. If there was mass, we do ultrasound first. And then to see the biliary channels, we can do MRCP or ERCP. In the treatment, because choledochal cyst can complicate into cholangitis, choledocholithiasis, or maybe cholangiocarcinoma, so the treatment should be cyst excision, Roux-en-Y hepaticojejunostomy. Cholangiocarcinoma, the commonest site is the confluence of right-left hepatic ducts or the hilum that is hilar cholangiocarcinoma, also called as Klatskin's tumor. In cholangitis, because of stasis of bile in this choledochal cyst, infection, acute inflammation, rubor, tumor, calor, dolor, functiolacia. Now, there may be sudden onset of severe pain in the right hypochondrium, high-grade fever, chills and rigors, and jaundice. This pain, fever, jaundice is Charcot striate. And this party in the bile duct can go into blood, which can lead to septicemia, septic shock, hypotension, mental confusion. Pain, fever, jaundice, hypotension, mental confusion, this is Raynaud's pentad. When patient is going in shock, the first duty of the doctor is to save the life. So you pump in IV fluids, give IV antibiotics, make the patient a bit stable, then do a quick LFT ultrasound. But because it's a big party in the bile duct, so IV antibiotic may not be able to control such a big party. To save the life of this patient, you have to reduce the septic load, for which you do a ERCP and stenting, endobiliary stenting. This is an emergency procedure, not the permanent treatment. In emergency, once you are able to reduce the septic load, you will be able to save the life of this patient. Maybe after a few weeks or months, you do a cyst excision and hepaticojejunostomy. Right? This is applied in all emergency cases. Now, intussusception is basically telescoping or invagination of one portion of the intestine into the adjacent part. Most commonly, it is the ileocolic. Most commonly presents at around 6 months of age, that is 5 to 10 months, and the reason is idiopathic. However, in children, there may be rotavirus infection, rotavirus vaccination, involution or hypertrophy of the Pierce patches, or maybe Meckel's diverticulum causing intussusception. In case of adults, the commonest intussusception is colocolic due to polyps in the colon. In intussusception, suppose 6 months old baby, ileum has gone into the cecum. Generally, it presents as a sausage lump in the right hypochondrium, or maybe in the left paraumbilical region with the concavity towards the umbilicus. We may find blood and mucus in stool, red currant jelly stool. We may find empty right iliac fossa, sign of dance. And on digital rectal examination, the examiner's finger can be stained with blood. If the baby is presenting with a lump, we do ultrasound where we see a donut sign, a target sign. X-ray abdomen can show us crescent sign or meniscus sign. Barium enema shows us a beautiful claw sign, or sometimes a coiled spring sign. However, better investigation for intestines would be CCT, and the treatment would be reduction of the intussusception by hydrostatic methods, where we can use either air or saline or barium. Air enema is the best because it causes minimal injury. If hydrostatic reduction fails, then operative reduction is done, where we do gentle push, milking of the outer tube to reduce the inner tube. Never pull in intussusception. If some portion is gangrenous, then we have to do resection, anastomosis. Lumbar region, ectopic kidney, left-sided most often, and the pelvis in the retroperitoneum. Polycystic kidney disease, multiple cysts in both the kidneys usually, can be congenital, can be infantile. Congenital is autosomal dominant, infantile is autosomal recessive. Congenital is very common, infantile is very rare and carries high mortality. Congenital is also called as adult polycystic kidney disease because though it is congenital, but it presents after 30 years of age. It can be associated with cysts in other organs like liver, pancreas, spleen, ovaries, most commonly liver. It can be associated with mitral valve prolapse. It can be associated with perianeurysm of circle of Willis. In polycystic kidney disease, most often the patient presents with hypertension, 75%, which is often gene related, There can be swelling and pain in both the lumbar region. There may be hematuria, there may be uremia as well. Clinical approach in lumbar swelling cases, first we do ultrasound, and on ultrasound we can see these polycystic kidney. Best would be CT, or we do IVP where we see spider leg appearance. In the treatment, we can try initially doing a de-roofing of the cyst, but eventually, because both the kidneys are going to fail, we'll end up in doing kidney transplants. In kidney transplant, generally we prefer left kidney from the donor because of long left renal vein. And this transplanted kidney is generally placed in the right iliac fossa. When we are putting a transplanted organ in a different anatomical location, we call it as heterotopic transplant, like we are doing for kidney. But in liver transplants, we are putting the transplanted organ in the same anatomical location, that is orthotopic transplant. When we are seeing the kidney, ureter, bladder areas, if you don't see the contrast, that is a plain X-ray KUB. If you see the contrast excretion in the pelvic ileal system going into the ureter, it can be IVP or IVU. However, there are various contrast studies for the urinary tract and the GI tract. Like for the urinary tract, the upper tract kidney and ureter, best would be IVP, IVU. We can do a retrograde pyelography, we can do an antegrade pyelography. For lower urinary tract, for bladder, we can do a cystogram. For urethra, we do a retrograde urethrogram. However, micturating cystourethrogram, voiding cystogram is advised in two scenarios: posterior urethral valves and vesico-ureteric reflux. GI contrast studies for esophagus swallow, stomach meal, small intestine, duodenum, jejunum, ileum, barium meal follow through, and for the colon, barium enema. Horseshoe kidney, 1 in 900, pair of ectopic kidney, fusion of medial subdivisions of lower poles of both the kidneys. Site of isthmus is L4, L5. L4 is the best answer. Inferior mesenteric artery does not allow the ascent easily. Usually, patient does not have any problems, but sometimes patient may be symptomatic due to stasis. There is a possibility that both the kidneys may enlarge, causing swelling and pain, but this swelling pain will not be in the lumbar region, it will be in the lower abdomen. Complications sometimes can be UTI, stones. If the patient presents with swelling in the lower abdomen, we do ultrasound. Our best would be CCT or IVP. CCT IVP can show us that flower vase ureter or the hand joining sign. In the treatment, asymptomatic, nothing has to be done. But if symptomatic complications, division of isthmus is not the treatment of choice, because liver, spleen, kidney are full of blood. Any incision or any trauma can lead to profuse bleeding from these liver, spleen, kidneys. So unless mandatory, avoid incisions on these organs. If there is UTI, give antibiotics. If there is a stone, we remove the stone. That is the treatment. Meckel's diverticulum, before that, the background. During intrauterine life, there is connection of the umbilicus with the intestine and the bladder. Intestinal connection, vitreointestinal duct or omphallomesenteric duct. Bladder connection, allantois, which after birth generally closes. But if it persists, if the intestinal connection persists, umbilical fecal fistula. If the bladder connection persists, umbilical urinary fistula. In umbilical fecal fistulas, you will find greenish, yellowish fecal discharge from the umbilicus. And in umbilical urinary fistulas, you will find urine watery discharge from the umbilicus. If only the umbilical end is patent, but the intestinal or vesical end is closed, it is just a one-sided connection with the skin, that is umbilical sinus, presenting with mucus discharge from the umbilicus. If the organ end is patent and the umbilical end is closed, then one-sided relationship with the organ will be diverticula. There can be Meckel's diverticula, there can be congenital bladder diverticula. Both are congenital diverticulas, which are true diverticulas because they contain all layers of the organ. Congenital should be differentiated from acquired diverticulas. Acquired, which are acquired later in life, and conceptually, whenever there is a traffic jam anywhere in the body, the proximal people will dilate, pressure in the proximal area will increase, which will force the proximal mucosa submucosa to protrude outwards, leading to acquired diverticulas commonly seen in elderly people. They are false as they do not contain all layers, they just contain mucosa, submucosa like Zenkus diverticulum, then acquired urinary bladder diverticula and sigmoid colon diverticulas seen in elderly people. Meckel's diverticulum, which is persistence of intestinal end of pitulo-intestinal duct, is a congenital true diverticula containing all the layers, located on the anti-mesenteric border, has its own blood supply, rule of 2, 2% population, 2 cm wide, 2 inches long, 2 feet, 60 cm proximal to ileocecal junction. 2% of patients can be symptomatic, and if symptomatic presents at around 2 years of age, consist of heterotopic lining, most commonly gastric. However, pancreatic colonic can also be present. If Meckel's goes into the inguinal hernia, such a hernia is Lichter's hernia. Usually asymptomatic but rarely present with symptoms mimicking acute appendicitis. Most common complication in Meckel's is bleeding. However, diverticulitis, diverticular perforation can occur, peptic ulceration, intussusception can occur, and intestinal obstruction is not because of Meckel's but because of a band from the umbilicus to the apex of Meckel's diverticula. Investigation of choice would be Meckel scan, that is technetium per technetate scan, especially when gastric lining is present. However, we can do CACT, barium meal follow-throughs, video capsule endoscopies, double balloon enteroscopies, enteroclysis type of investigations. If patient is asymptomatic, nothing has to be done, but if symptomatic or complicated, depending on the mouth of the diverticula, if it is narrow mouth, diverticulectomy, wide mouth resection, anastomosis, where we use linear staplers. If Meckel's is found incidentally at laparotomy, when we are doing this laparotomy for some other reason, then if Meckel's is having a narrow mouth, we can do diverticulectomy because narrow mouth diverticulas have more chances of creating complications. But if it's a wide mouth diverticula incidentally found at laparotomy, then we can leave it as such as well. Hirschsprung disease or congenital megacolon, congenital aganglionosis. This is absence of ganglion cells, most often in the rectosigmoid area where rectum is always involved due to failure of migration of neural crest cells. Depending on whether short segment or long segment is aganglionic, if only short segment is aganglionic, the story presents in OPD in childhood with constipation. And if this constipation is not settling even after some simple methods like dietary modifications, then we want to know the cause. We do barium enema, which can show us the extent of disease. The narrow contracted part is aganglionic, while the proximal dilated part is normal. To know the severity of obstruction, we do anorectal manometry, but to conclude the diagnosis or the investigation of choice, we have to demonstrate absence of ganglion cells, so suction rectal biopsy. And then in the treatment, we can do Duhamel, Swenson, and Sove type of coloanal anastomosis. However, if a long segment is aganglionic, then the story presents immediately after birth, maybe 4 or 5 days of life. A neonate who cannot pass meconium at all, the proximal colon has distended, baby presents with gross abdominal distension, risk of colonic rupture in the peritoneal cavity leading to peritonitis, septicemia, and death. So in this emergency, in the newborn baby, we do a proximal colostomy. All colonic obstructions, all large intestinal obstructions, emergency treatment would be proximal colostomy. In the hypogastrium, duplication of renal pelvis ureter. Most common congenital anomaly of the upper urinary tract is duplication of renal pelvis and ureter. In duplication of renal pelvis, we can find a drooping lily sign. In hydrated cyst, we can find a water lily sign. In duplication of ureter, there is a Mayer-Weigert law which says if there are two ureters on one side, generally both of them join, so there is only one ureter going into the bladder, normally opening in the bladder. But rarely there is a possibility that two ureters do not join, and if they do not join, then the lower ureter opens normally in the bladder, but the upper ureter passes distally and open more medially. Like in boys, most common site of ectopic ureter would be apex of trigone. However, it can open in the ejaculatory duct, seminal vesicle, posterior urethra, or even anterior urethra. In case of girls, ectopic ureter opens distal to the distal sphincter, which causes continuous dribbling of urine, dribbling urinary incontinence in girls. While in boys, this ectopic ureter can lead to recurrent UTI. To diagnose these double ureters, double pelvis, we can do a CCT, we can do a IVP, IVU, and the treatment would be, if ectopic ureter is causing problems, we just put this ectopic ureter back into the bladder, that is ureteric re-implantation. Retrocaval ureter is normally the right ureter is on the right side of IVC, but due to congenital anomalies may be related to the cardinal vein IVC abnormality, the right ureter may loop around the inferior vena cava, and inferior vena cava may press on the right ureter, causing traffic jam, leading to proximal right-sided unilateral hydro or hydroureteronephrosis. Usually the site is L3, L4 level. When we do IVP, IVU, we may find reverse J sign or fish hook sign. Because this retrocaval ureter sometimes can lead to urinary tract infections or stones, if the patient is having symptoms, then we do ureterostomy, or we can do pyeloplasty as well. Ureterocele, this is partial atresia of the ureteric orifice, which causes a dilatation of intramural ureter. Mura means muscle of the bladder detrusor. So that portion of the ureter which is within the bladder wall gets dilated. This is common in females, seen in childhood, recurrent UTIs. When we are doing IVP, IVU, we find that cobra head or adder head appearance. And the treatment would be surgical excision of this ureterocele and ureteric reimplantation. Earlier we were doing endoscopic incision of the ureteric orifice, which caused vesico-ureteric reflux. In the boy's urethra, posterior urethral valves, these are basically flaps of urothelium located just distal to verum montanum in the prostatic urethra only in boys. This is the most common cause of urethral obstruction in a male child. Depending on whether these valves are complete or incomplete, if they are incomplete, we know the direction of valve is such that they can allow anything to pass from below upwards but will not allow things to pass from above downwards. If the valves are incomplete, there is some space in between. So this story presents in childhood with recurrent UTI, where we do micturating cystourethrogram or voiding cystogram to make the diagnosis, and the treatment would be endoscopic fulguration of these valves, that is transurethral fulguration of these valves. However, if these valves are complete, there is a complete traffic jam in the urethra, and the story will present in the neonate, newborn baby will not be able to pass urine. Retention of urine, we do a suprapubic cystostomy to relieve the emergency. Hypospadias is the most common congenital anomaly of male urethra. 1 in 300 male live births. Depending on whether the external opening is on the glans or the penile shaft or other areas, we can classify this hypospadias into glandular, coronal, subcoronal, distal penile, mid-penile, proximal penile, pinoscrotal, scrotal, perineal. Opening which is more close to the normal will be more common and less severe. Opening which is far from the normal will be less common and more severe. Glandular is the most common, least severe, does not require any treatment. Perineal is the least common, most severe. In perineal hypospadias, sometimes sex is difficult to differentiate. Use of diethylstilbestrol during pregnancy increases the risk of hypospadias in the baby, and in hypospadias there is ventral curvature of the penis, that is ventral chordae, and there may be meatal stenosis. The problems in the baby can be urination, erection, and deposition of sperms, for which surgical correction is required at 10 months of age, usually between 6 to 18 months of age, chordae correction and urethroplasty. For making a new urethra, we use prepuse. So circumcision is contraindicated in hypospadias babies, even if it's a Muslim or a Jew baby. And one of the interesting complications of hypospadias surgery which can occur is urethrocutaneous fistula. Undescended testis cryptorchidism. The testis follow a definite path of descent during intrauterine life and reaches to the bottom of the scrotum just before birth. If the testis is arrested anywhere in the path of descent undescended, deviate from the path, go somewhere else, ectopic. If testis started developing in intrauterine life but disappeared before birth, vanishing. If testes have normally descended into the scrotum but due to contraction of the cremasteric muscle, they ascend up into the inguinal canal, but they can be brought down to the bottom of the scrotum just by manual manipulation. This is retractile and no treatment is required for retractile testis. Undescended testis is the most common congenital anomaly of male genitalia. 3% in full-term baby, 30% in preterm, 50% right-sided, 30% left-sided, 20% bilateral. 75% of undescended testes descend down to the bottom of the scrotum within first 3 months of life. Histological changes start appearing in undescended testes after 1 year of age. The commonest site of undescended testes is high up in the scrotum and the second is inguinal canal. The commonest site for ectopic testis is the superficial inguinal pouch or the Dennis Brown pouch. However, ectopic testis can be found in the femoral triangle or root of penis or in the perineum. Sometimes complications occur in undescended testis, remembered by the mnemonic A testis: atrophy, trauma, epididymoarchitis, sterility if both the testes are undescended, torsion. Inguinal hernia is the commonest complication of undescended testis, and seminoma. How to approach these babies? If it's undescended testis, clinical examination is very important, where we may or may not be able to feel the testis, maybe high up in the scrotum or in the inguinal canal. If we are able to feel the testis, we get the ultrasound done and take the confirmation. But if we are not able to feel the testis, or even ultrasound cannot localize the testis, then the gold standard investigation for localization of non-palpable testis is diagnostic laparoscopy. In the treatment, we have to bring the testis down to the bottom of the scrotum and fix it to the bottom of the scrotum, which is called as orchidopexy, generally done between 6 to 18 months of age. However, if 6 to 18 is not given in the option, then 6 to 12 months of age. Imperforate anus, when the anal opening is missing, it can be a low or high anomaly, maybe only the opening and anal canal is absent, or maybe opening anal canal and rectum is absent. Earlier we were doing invertogram to see this. After 24 hours of birth, we used to turn the baby upside down, put a marker at the potential site of anal opening and measure the distance between the potential site of anal opening and the gas shadow, deciding whether it's low or high. That was invertogram. But now we are taking the X-ray, lateral X-ray in prone position, and we can find out the same. If it's a low anomaly, we do anoplasty. If it's a high anomaly, we do posterior sagittal anorectoplasty. Thank you very much. I hope we are able to complete the revision of pediatric surgery nicely. Let me just have a look if you have got any queries.